and giving patients choice was a key part of that. A much stronger voice for what we call local commissioning. We don't really even have that in our system. But in Britain, you know, the idea of separating the commissioning, the buying, the assessing of need, if you like, population's health needs on the one side, and the delivery of it had been separated. So you have commissioning bodies that are given most of the money, 75% of the NHS, I think now up to 80% of the NHS budget. We're talking like, you know, billions, to purchase health on behalf of their population. That's demand, you know, and I think neither of these elements exist very strongly in the Canadian healthcare system. And they didn't in the NHS that well until a few years ago, and I think they're critical. Supply. We do have supply here, and very good supply, but I think the element that was introduced here, very controversial, was the idea of contestability with diverse providers, with more local power to challenge the existing NHS. Again, not highly popular always amongst those in the providing world, possibly waste, you could even say, by having competition. But I think anyone who's looked really at efficiency of systems, you know, monopoly supply, paid for by taxation, has not got really any tradition of innovation, patient responsiveness, and you know, adaptation to challenge of change. So you know, the idea of contestability has been key. That means really having a competition at the degree of supply between different providers. Not all private public, some of them could be two privates, or two publics, or if I'm running, you know, a really good public service in a particular specialty in one hospital, I might want to provide it across town. I'd be able to do that. And in terms of motivating and incentivizing people who are providing care, that's actually, being able to expand is actually quite often an interesting thing to be able to do. And each one of these things you could say more about, but it was a very important component of developing supply. New transactional forms, the third element. This is a complete change in the way we fund the system. We fund institutions here. We reward spending. If you spend more, you get more. If you have a deficit, you accumulate it until it gets so big the government has to pay it off, basically, because that's the time you're going to sink our balance of trade and our credit ratings. And there's really very little you can do to stop that. It's very hard to do. There's a set of perversities in the system which funds institutions as blocks. This system is trying to have the money follow the patients and rewarding the best and most efficient by incentivizing improvement. And that means there's been some standard tariffs set for particular operations, you know, and there's it's the simplest way really of using the system itself and the competitiveness and purchasing within the system and the demand within the system to begin to get rid of some of the more dangerous institutions who shouldn't really be providing care when they're not doing it very safely or well. We've also managed to get at some more costly elements, you know, some hospitals that shouldn't really be in certain businesses because, you know, they should be gone upstream. Anyway, the whole, by transactions, it's that, you know, the actual way in which services are funded at the level of the individual episode. And then finally, fourth, the national framework. And this really means having a system of regulation and decision-making which guarantees, you know, quality, fairness, equity, value for money. You need a regulatory framework. You don't want to be, you know, the tendency in public services is to sort of try and control the institution through a hierarchy of command and control and ask for accountability. If any of you work in the system, you probably spend a certain amount of your life filling forms in about what you did with your time. And somebody else up the line is filling forms about what they did with their money, and then that goes up the hierarchy, and then some poor sod in the ministry tries to figure out, look into all this stuff, if it's going, you know, if you're really using it well or not. Now that, you know, it's a series of second guessings up the hierarchy. This is trying to really change that system so that you've got a regulatory system where actually the incentives are going to be structured really at a local level about whether or not you use your money well. And if you do use it well, by generating surpluses instead of deficits, you're allowed to use that money for some other purpose. Anyway, it just really tries to change the system as a whole. And you know, if you have to provide a simple structure to kind of visualize this for those of you who think more spatially, you know, that's what, in the center there's this box that says, you know, better care, better patient experience, better value for money. Those are the kind of key objectives. And what you have around it are the, you know, the four elements of the new system design. Money at the top, money following the patients, rewarding the best and providers, giving others the incentive to improve, and then ultimately becoming free by being foundation hospitals, so that they begin to own their own property, they can borrow on it, they can operate more like a business. But they aren't a business, because ultimately, they don't charge services for the people using them. But they are given an incentivized system so that they're more able to use the money in a way that can produce more healthcare. On the left side, more choice, stronger demand management for patients and populations. At the bottom, the framework of system management, regulation, national clinical excellence, trying to determine what services and clinical procedures should work, what drugs should be used, and that's determined across the board. And then finally, the quite controversial, diverse providers with more freedom to innovate and improve services. Now that's the thing that gets a lot of attraction, because there is an element of private provision that's been introduced into the National Health Service. I have to say, experience of sitting in Downing Street buying private hospitals, I think if I'd been there in the late 40s, I'd have said we were nationalizing hospitals. But it's a different world, politics are different, so we said we were privatizing them. Spot the difference. Public money, use free, but introducing, the capacity, the managerial ability, the plant, and resources of the private sector, but injecting some element of competition within the system. So it bears a little more look than the usual kind of immediate reaction that it seems people are putting their hand in their pocket and paying for healthcare, because that I think is a very different arrangement. Okay, that's all the time I have. So the slides will be around, and you can look at them if you want to see in more detail some of how this backroom system. But just to show that the achievements of this system are not just about the feel-good factor of patients being able to choose and book their own procedures, although that's pretty useful. But it's also, very uncontested achievements, really, in delivery. This one, waiting times, reduction in waiting times. Outpatient is the light green, inpatient is the green. So you see a very dramatic change from 97. Obviously, these figures are always political. 97, Labour government started that way, but it also happens to be a 10-year period. I think you can just read that it goes down. The vertical is the minimum waiting time in weeks, so the maximum waiting time in weeks, I should say. The way these data are set up is also interesting, which is that it's not set in averages. It's that no one will wait. No one will wait, whatever the waiting time is. That's politically very different, right? Because no one can experience an average. But if I say no one will wait more than 4 hours at the emergency, if I go to emergency and I wait more than 4 hours, they failed. Whereas if they tell me that emergency runs an average of 4 hours wait, well, I figure I was one of those unlucky sods who had to wait 3 days, but on balance. So, these were these targets were set very consciously. Anyway, I'm not going to be able to go through these. There we are, pretty much across the piece, even in outcomes in terms of circulatory disease mortality rates, you actually see tangible improvements. So what were the conditions of what I consider to be, I'm a practitioner, you see, I'm not being so much of an intellectual at this point, but what were the conditions? I think that, political and managerial leadership who was prepared to really take on some of these things. Engaged clinicians, not sufficiently engaged, but I think the beginning you needed to have more engagement, would have been helpful to have more engaged. A phenomenal data and analytic capacity, which I don't actually experience in quite the same way amongst some of our Canadian information institutions, but I think they could be developed in that way. Systems which are meant to adapt themselves rather than have to wait for a command and control direction from the top, which is largely how public services work, and which makes them often unpleasant places to work. And finally, the continuity. I mean, having a 12-year run at reform is, pretty unusual in electoral systems. Quite often you're running for the next 3 years, and you hope, if you're lucky, you might get another one. But you can't be counted on. So this took a long term. Sorry I took so long, but I hope that's given you some idea of what we are trying to do and the payback for patients. Again, you're probably going to get a big smorgasbord of different presentations here this morning, coming at us in very different ways. But